And just because of technology, I'll start this by saying, can you hear me now? Can you hear me now? So, okay, terrific. Thank you, Julia, for those kind words. I am Danette Taylor. I recognize a number of faces. Many of you may remember that I, in fact, did practice over here for several years, and it was 4 years ago that I moved over to the west side of the state. And I do miss seeing so many people on this side of the state. So today we're going to talk about sleep, so I hope you're all awake right now, and I hope my presentation does not knock you out. So in terms of disclosures, I have had some research support from a couple of companies, so I thank them very much for allowing me to participate in clinical research, but otherwise I really don't have anything to report, and that's not going to interfere with my talk today. So what are we going to talk about? We're going to talk about sleep and Parkinson's disease, and we're going to break that up into a couple of sections. Number one, why do we sleep, and how do we sleep? Number two, how does Parkinson's disease affect sleep, and what can we do about those things? So, and I'm hoping that this is not going to occur. Especially at the end of the day like this. So anyway, as we are adults, our average amount of sleep is about 8 hours. Now, most of us know that that's not always the case, and if we're lucky enough to get 5 or 6 hours, we're pretty happy. If we are sleeping well, sleep latency is about 10 minutes. Now, what the heck is sleep latency? That is when we go to sleep, the amount of time it takes us to actually fall asleep. And so if your sleep latency is less than that, you're considered a little bit sleep deprived. If it's more than that, then you may not be tired enough to actually go to sleep, or you may be experiencing some issues with insomnia, and that's something that we can look at. Normal sleep structure is broken down into stage 1, stage 2, and then sources look at either stage 3 or stage 3 and stage 4, or lumping stage 3 and stage 4 together into the deeper stages of sleep, and then what we call REM sleep, which stands for rapid eye movement sleep, and that's when we're dreaming. Now, all of those stages of sleep are important, but it's those stages 3 and 4 that are the very restorative stages of sleep for us. Now, for Western cultures, napping tends to occur mostly at the beginning of our lifespan. Nobody thinks twice about an infant or a toddler napping. And then as we get a little bit older, napping becomes a little bit more common as well. Not quite as acceptable for those of us, still in the workforce to take a mid-time siesta from noon until 3 or 4 to be taking a nap, but maybe we should be. So, what is typical alertness versus sleepiness in a 24-hour time frame? Just very briefly, we talk about process C, and then the circadian rhythm, process C, and then the sleep-wake balance, or process S. I'm not going to get really deeply involved scientifically into this, but bottom line is the process S really depends on how much time it has been since you last slept, and the longer you're awake, the sleepier you get. The circadian rhythm is a normal rhythm that we all have, and when that is functioning the way it's supposed to be, when it's dark out, we get sleepy, we sleep during the night. When we're exposed to bright light, we're less sleepy, we're more awake. But many of us have a circadian rhythm shift, or our circadian rhythm gets disrupted, and that can lead to significant problems with our ability to sleep through the night. So sleep architecture, as a little misspelling there, sorry about that. So non-REM sleep stages, as we just mentioned. Stage 1 lasts for a very short period of time. We're just starting to fall asleep. This is the stage of sleep that if somebody comes by and wakes you up, you're going to deny that you were even sleeping. Oh, I was still awake. I wasn't really asleep at all. But if we were to hook you up to an EEG or a brainwave test, it would show us that, in fact, you were asleep. Stage 2 lasts for a little bit longer than that. We need a little bit more intense stimulation to wake us up during those stages, but it's still pretty easy to be awakened. Stage 3 and 4, as I mentioned, the slow wave sleep, lasts for a longer period of time. It's much more difficult to wake us up when we're in those deeper stages of sleep, and so that is what we call slow wave sleep. As we were to be hooked up to a brainwave test, we would see that our brain rhythms really slow down and show us the typical characteristic changes of the electrical activity in our brain when we're sleeping. And that's more prominent earlier in the evening or earlier in the nighttime. REM sleep behavior, or REM sleep, is more prominent a little bit later through the night. We cycle through these stages of sleep multiple times every night. Each of these stages, starting at stage 1, going through REM sleep, lasts anywhere from 60 to 90 minutes. And if we're sleeping for 7 or 8 hours, we're cycling through that, 5 or 6 times each night. So, and all of those stages are really quite important. So when we get a little bit older, and this kind of harkens upon a little bit of what Dr. Espay was just talking about, right? What's Parkinson's disease and what's normal aging? We do know that as we age, our total sleep time tends to decline to some extent. What might be normal amount of sleep when we're younger, 10 or 12 hours, even 14 hours for some toddlers going through a growth spurt, is much less when we're older, and sometimes normal amount of sleep for older adults is really only 5.5 to 6 hours, and that's okay. We do see that slow wave sleep and REM sleep tend to decline to some extent, and that might be a little bit of a problem. And why is that? Well, let's talk about why do we sleep. We don't really know. I mean, this is all speculative, right? Nobody knows specifically why we sleep, but one very prominent theory and very kind of exciting theory has to do with what we call the glymphatic system. Now, how many of you have heard of the glymphatic system? There are a few hands that are coming up. This is kind of like, outer space. It's a new a new discovery, and we think that we know everything there is to know about our body, but the glymphatic system was really just discovered a relatively short time ago, and this seems to be, this is really a crude way to describe it, a garbage disposal system for our brain. It works specifically while we are asleep, and all sorts of bad actors get flushed out of our system while we are in the deep stages, those stages 3 and 4. That's when this glymphatic system is most active and seems to be clearing out a lot of really bad things that are occurring within our brain. And when those bad things don't get cleared out as well, then we theorize things like Alzheimer's dementia or Parkinson's disease or other neurodegenerative diseases really seem to be occurring more and more. So what happens if we don't sleep the way we really need to be sleeping? We might have decreased problems with memory. Our ability to pay attention is much less. Our mood is not nearly as good. We're more irritable. We're depressed. We're apathetic. Impaired immunity, what the heck does that mean? We're more susceptible to things like colds or influenza or other viruses that are floating through the system when we are not sleeping as well as we could be. And even things like our ability to metabolize glucose after a meal, and our risk of developing things like diabetes is much higher if we're not sleeping well. increased blood pressure, weight gain, and then even problems with increased risk of falling is much higher if we're not sleeping as well as we could be. And this is really just kind of a schematic that kind of shows specifically what problems can occur when we don't sleep as well as we need to. And I don't know if you can see that, there are lots of car accidents that can occur. We have increased cravings for junk food, and I know this is a really difficult thing to see. It's really just a schematic for what we've just looked at, but risks of heart disease, high blood pressure, and so on, much, much higher when we don't sleep as well as we need to. So what impacts our ability to sleep when we're an adult? How many of these things look familiar to you? We have bad habits which lead to poor sleep hygiene. Maybe we have some health problems. Maybe we're frustrated with family members, or an outside thing has led to some frustration and anger. Maybe we have some mood problems, and there may be other issues that are contributing to our inability to actually fall asleep at night. But all of these factors can be contributing, and that alphabet soup up in the upper left-hand corner, RLS, PLM, OSA, restless leg syndrome, periodic limb movement disorder, obstructive sleep apnea, are all things that we think are probably not really all that much of an issue, but can make a big difference in terms of our ability to actually get to sleep at night. So let's talk about insomnia briefly. We break insomnia down into primary insomnia versus a secondary insomnia. Primary insomnia means that you haven't been able to sleep even before a diagnosis of something like Parkinson's disease or a different chronic condition. Secondary insomnia, probably related to a diagnosis of a chronic condition, specifically like Parkinson's disease. And what does primary insomnia mean? An absolute inability to get to sleep or stay asleep. Maybe we wake up very, very early. Ideally, this is something that lasts for a very brief period of time, less than 4 weeks. But most people that have insomnia develop issues with what we call chronic insomnia, which means it's lasting for far longer than 4 weeks, in some cases many, many years. And it's sometimes very, very difficult to treat. And there is a theory of what we call kind of a chronic or learned insomnia, that a transient insomnia occurs during a period of stress. We're frustrated when we can't get to sleep. We have delayed sleep onset, which disrupts our sleep. We have worry about how we're going to function during the course of the day. And then that cycle kind of begins to replicate itself day after day after day because we're more and more worried about what's happening with sleep. So how does Parkinson's disease specifically impact our sleep? Well, let's go back to what Parkinson's disease really is. And this is a little bit of a review, but the more we hear things, the more we know them, right? So that's okay. James Parkinson's first described Parkinson's disease more than 200 years ago. And a lot of what he did was really based on observation of people from a distance. And one of those cases, in fact, described what appears to be probable REM sleep behavior disturbance. He described somebody of, quote, the patient's caregivers observed movements during sleep that increased until they awakened him when he was always in a state of agitation and alarm. And so in retrospect, it may well be that issues with sleep behavior disturbance have been long-standingly associated with Parkinson's disease. We certainly know that we see those frequently now. So we do know that Parkinson's seems to be increasing, and we're not going to go into everything. Motor symptoms of Parkinson's disease, I think you guys are probably well aware of all of these issues: tremor at rest, slowness, rigidity, changes in arm swing, some decreased size of handwriting, and I think we've seen this slide already, the postural changes, example of micrographia. In addition to all of the motor symptoms of Parkinson's disease, we're talking more and more about issues with what we call the non-motor symptoms of Parkinson's disease. And we've recognized that these non-motor symptoms can be just as problematic for many people as motor symptoms. And we heard earlier today a terrific talk about orthostatic hypotension, or a drop in blood pressure, and how that impacts Parkinson's disease. Constipation can be seen and associated with Parkinson's disease. Not only can that be uncomfortable, that can impact how well your medications work. Urinary urgency, depression, anxiety, cognitive decline, hallucinations, and what we're here to talk about right now, sleep disorders. And so all of these things very commonly identified with people with Parkinson's disease. What are the incidents of what we call these non-motor symptoms, ranging from 30% for memory problems up to more than 90% of people who have changes in their sense of smell. And in the middle of that is issues with sleep. Now, this slide suggests it's maybe about 2/3. In actuality, it's probably more than 95% of people with Parkinson's disease have some kind of a sleep issue. And what is that sleep issue? Not everybody is the same. We just heard Dr. Espay talk about that, right? This is a heterogeneous group of disorders, and everybody is different. And the sleep disturbances that we see range from insomnia to excessive daytime sleepiness, to that disorder of circadian rhythms that I had hinted at previously, to restless leg syndrome. Parasomnias is kind of just a word that we use to describe things like acting out dream behaviors, so shouting in your sleep, or actually moving about, or maybe even getting up and walking about while you're still sleeping. And then even things like breathing problems while we're sleeping can be seen in patients with Parkinson's disease. So what are the causes of these issues for insomnia to start? Maybe it's because we're stiff and rigid and we can't really begin to relax. Maybe our tremor is really, really problematic when we're trying to fall asleep at night. Maybe our medications are beginning to wear off in the middle of the night, and that wearing off effect of that medication wakes us up. Or maybe there's something else going on. So bottom line, it's not a one-size-fits-all, and sometimes we have to do a little bit of digging to figure out exactly why you might not be sleeping as well as you'd like to be. Maybe we're seeing things that your tremor is bothersome, and so you need to take a dose of medication, allow it to get into your system so that when you're ready to go to sleep, your tremor is controlled and you can get comfortable in bed, pull up the sheets and blankets the way you need to, roll over so you can actually get comfortable, and then fall asleep. Or maybe your medication is wearing off too early, and then we can talk about tricks to try to help extend the duration of action of medication so that a wearing off effect doesn't wake you up. So, or if you're waking up for other reasons, such as to use the bathroom, maybe you take a dose of medication during that time to allow you to sleep for the rest of the evening. So those are all things to consider, but the best approach really is going to be based on what your identification of what you're specifically experiencing might be and how you describe that to your physician. So we know that patients with Parkinson's disease are at much higher risk of developing issues with depression and anxiety. And it's not just because you're reacting to your Parkinson's disease. This is a dopaminergic dysregulation, and dopamine does much more that help us move fluidly and control our tremor. It also helps with our mood stabilization, and when that dopamine isn't as stable as we'd like it to be, mood issues can be identified. Well, and when mood issues are problematic, that can lead to issues with sleeping. So anxiety can make it very, very difficult for us to fall asleep at night. If we have issues with depression, it may make it difficult to actually fall asleep, or maybe we want to sleep too much. Maybe we wake up far too early if we have issues with depression. Depression is one of those premotor symptoms or non-motor symptoms that may predate Parkinson's, the actual motor symptoms of Parkinson's disease, for really quite some time. We do know that medications can be very effective in treating both of these conditions, but anti-anxiety medications can be associated with causing some sleepiness. Sometimes antidepressant medications can worsen issues with insomnia. So that's something that we have to look at closely. So how do we treat chronic insomnia? You know, initially we want to look at sleep hygiene, and most people don't want to hear that. They want to say, well, what's the best pill for me to take so I can sleep at night? And maybe that's not the best choice. Sometimes we need to look at, are you drinking too much caffeinated beverages earlier in the day? Are you relying on alcohol to actually fall asleep at night? We know that while alcohol acts as a depressant and can knock you out early, it actually impedes your ability to get into the deeper stages of sleep, and so you are more restless after a few hours. And so that may actually kind of backfire in terms of your attempt to continue to sleep through the night. When we have insomnia, we often say, well, I slept really poorly last night, so I'm going to do my best to sleep during the day today. And then we get into this bad cycle of sleeping during the day, and so then we can't fall asleep at night. And so we're kind of getting this skewed rhythm, and we wonder how we can get out of that, because it feels as though there's no way we can stay awake through the day because we hadn't slept the night before. So that's something we want to look at. So, but sometimes, you know, when we're trying to get to sleep at night, going to bed only when we're ready to go to sleep. You don't have to have a regular bedtime. Mom's not telling you it's 9 p.m., time to go to bed now. When we're ready to go to sleep, we can go to sleep. If we are in bed and we're sleeping, you know, more than 75% of the time, we're probably doing a pretty good job. So we don't want to get into this fatalistic viewpoint, oh, I never sleep at night. So we want to make sure that we get in bed, we're monitoring what we're doing, we're kind of calming things down. Let's think about how we behave with a young child and getting that young child to wind down. We're not going to play a horsey bat game or bounce the kid around right before we try to put him down. We're going to do some more calming type activities and kind of help that child wind down, and that might include things like a bath, and then a story, and then maybe even a song or a cuddle, and then things are calmer and the child is able to go to sleep. Well, we can give ourselves that same type of behavioral response and say, okay, I want to go to sleep at 10 or 10:30. At 8 o'clock, I'm going to start winding down. I'm going to start decreasing my exposure to television or my computer or my emails or anything along those lines. I'm going to maybe read a book or do a crossword puzzle, or maybe do some meditation. Maybe I'll take a shower or a bath to help relax a little bit more, and then I'll be able to fall asleep a little bit more readily. But that stimulus control can actually be very, very helpful. And for people that say, oh, I've tried that and it doesn't work, if you have had issues with insomnia for a long time, you're absolutely right. You try this once and it's not going to work. It takes a long time to change some habits and to develop some new habits. So if you tried it and it didn't work immediately, don't be discouraged. You have to keep working at it. So medications that can be used, antihistamines, very commonly used. I think probably the most common one is our old friend Benadryl, right? And we know that that's commonly found in many, many over-the-counter sleep preparations. If you read the labels, they say don't use this for more than 2 weeks in a row, because it will lead to what we call rebound insomnia, meaning you won't be able to fall asleep without it. And for people who are over the age of 60 or 65, using medications like antihistaminic medications for sleep on a regular basis can actually cause problems with our memory. And so it's not a great choice to use routinely. There are many different antidepressants that sometimes can help us fall asleep at night, but may lead to some other issues through the course of the day. And so that best choice is the one that's not going to interfere with any other medical conditions that you might have. And so I'm not going to go into these specific brand name medications, but you can certainly ask your physician about them. But most of them are not meant to be used every single night for months to years in a row, which is very often how they are used, frustratingly. So natural things like melatonin or valerian root, even chamomile tea, can be very beneficial for some individuals. A lot of people don't like to use those because they say, quote, they don't work. None of those over-the-counter supplements are going to knock you out like a prescription medicine does or like Benadryl does. We know that. But they can improve your ability to stay asleep through the night and get a more restful sleep, but they're not going to knock you out within 15 or 20 minutes the way other medications might. So things that might worsen insomnia, various antidepressants can sometimes make us more awake, and if that's the case, taking them earlier in the day versus later can sometimes be helpful. Most of us, or many of us, drink coffee routinely, and we forget that the caffeine effect can actually last many hours longer than we anticipate. And in some cases, that caffeinated effect can last for 8 hours or even 10 hours after a cup of coffee. And so if you're somebody that's drinking coffee at 4 p.m. or 5 p.m. or 6 p.m. or 8 p.m. and wondering why you're not sleeping as well through the night, that might be something to look at. Now, we do know that our response to things like caffeinated beverages change over time and as we age. And so if you were somebody that used to be able to drink coffee at 8 p.m. and never have any problem, and now you're saying, well, now I'm not sleeping very well at all, that might be something to really look at, because things do evolve and change as we move ahead. We know that medications that we use to help us breathe can sometimes act like caffeinated beverages and keep us awake. And even some of the medicines that we use to try to help control Parkinson's disease, like dopamine agonists or long-acting dopamine agonists, can sometimes cause what we call a paradoxical insomnia or make it difficult for us to fall asleep. So if you are having difficulties, that might be the first thing to do is take a very close look at your list of medications and find out, might there be a side effect of sleep problems associated with any of those. Just a little bit of a break. I think many of us can relate to this. How well I sleep when at work, when watching a movie or a television program, unfortunately while driving, falling asleep, and then laying in bed at night. So. Excessive daytime sleepiness is very common complaint of people with Parkinson's disease, especially if they haven't slept well the night before. And that's something that we want to look at. And then frustratingly, even if you have slept well, some of the medications that we use may cause some sleepiness. Maybe you have issues with sleep apnea. There are many different scales that can be done to help identify if you have what we call pathologic excessive daytime sleepiness, and if that's something we need to address. And that might be the Epworth Sleepiness Scale, the Multiple Sleep Latency Trial Study, Parkinson's Disease Sleep Scale, or a SCOPA scale, which is a evaluation Parkinson's sleep scale. And it's just a multi-step. It's very, I know that's very difficult to read, but it's got very many questions that ask, you know, when are you most likely to fall asleep? When you're sitting quietly, after a meal, if you're at a lecture, if you're in a car as a passenger, when might you be likely to fall asleep? And it's important to know, because that way those things can be addressed. Circadian rhythm disorders and Parkinson's disease, as we've already talked about, the circadian rhythm is normal for all of us. Our brains create melatonin at night. So melatonin is that natural substance that we can purchase over the counter, but it's also made by our brain. And in the evening hours, when it begins to get dark, melatonin begins to surge, and that helps us begin to get sleepy so that we can fall asleep and stay asleep. And then when we're exposed to bright light, melatonin drops down, so we're more awake. Now, the whole circadian rhythm thing can be thrown off by Parkinson's disease. Issues with dopamine and dopamine irregularities and imbalances can impact circadian rhythms. Even in patients who have never been on levodopa, which turns into dopamine in our brain, may have issues with circadian rhythm problems. If patients have changes within their sleep architecture, they may have what we call bradysomnia, or more issues with trying to fall asleep. And then the question is raised, is circadian rhythm dysfunction caused by Parkinson's disease, or does it cause Parkinson's disease? And again, that's a great question, and one theory has been raised that the suprachiasmatic nucleus, which is a normal anatomic part of our brain, which helps regulate sleep and wake cycles, begins to be a little bit off. And when that is not functioning appropriately, we develop issues with some sleep dysfunction. And when we have sleep problems, then we can develop issues with neuroinflammatory changes. We may have decreased metabolic clearance. Remember that lymphatic system that I shared with you? We may have more oxidative stress within our brains. And then we know that all of those changes may contribute to issues with Parkinson's disease. Now, the downside is that when all of those changes then begin to occur, they then feed back onto that suprachiasmatic nucleus and our brain's clock. And so then the whole cycle becomes impaired and is broken. So which came first, the chicken or the egg? That's a great question. And I think as we answer that, as we move forward, that will be one more way that we can help alleviate the issues associated with Parkinson's disease. So as we move forward, another condition that patients with Parkinson's disease are very prone to is restless leg syndrome. How many of you have heard of restless leg syndrome? So, yeah, exactly. There's a little bit of a misunderstanding about restless leg syndrome. A lot of people think that if my leg is moving, that's restless leg syndrome. Restless leg syndrome is actually a sensation within your legs, kind of a creepy, crawly sensation. Some people describe it as very uncomfortable, discomfort, almost painful type things. But that movement or that sensation goes away if you voluntarily move your legs. And so by moving your legs, this sensation goes away, but that feeling may make it very difficult to fall asleep at night. Many people with Parkinson's disease do have restless leg syndrome. Fortunately, it can be treated with dopaminergic medications, so the medications that you're on for your Parkinson's disease may help that sensation of restless leg syndrome. It's very common within the population. Associated with restless leg syndrome is a condition that we call periodic limb movement disorder. Now, if you are somebody that is sleeping and you have some jerking or twitching of your leg or even your arm while you're sleeping at night that seems to be kind of stereotyped or rhythmic or repetitive through the night, you may well have periodic limb movement disorder. And periodic limb movement disorder can be disruptive for you. It can wake you up. You may not wake completely out of a sound sleep, but you may wake into the lighter stages of sleep, so the less restorative stages of sleep. Periodic limb movement disorder may be problematic for your bed partner or your spouse that is sharing a room or a bed with you because it's waking them up. So, and sometimes periodic limb movement disorder is very common as we're beginning to fall asleep. So just fall asleep and then our leg kicks or jerks and then wakes us up, and then we have to start the whole cycle again trying to fall asleep. So if that is something you're experiencing, it can be identified typically with a sleep study or sometimes just based on history and can be treated. So REM, sleep behavior disturbance, and Parkinson's disease. Most people, when they begin to dream, don't move at all. There's some kind of a switch in our brain that is thrown, and when we're dreaming, we can't really move. And so if you're remembering back to when you were a kid and you were chasing somebody, it was so hard to move during that dream, it just can't move. That's because of that relative, what we call atonia, or our inability to move about. Well, there's something about Parkinson's disease that switch is a little bit faulty, and many people with Parkinson's disease act out their dreams quite prominently. And so they may be punching, they're doing rock steady boxing in their sleep, or they're doing Parkinson's dance moves in their sleep, or they're running to get away from somebody. Sometimes so much movement is occurring that patients actually fall out of bed or get up and move about. And so that is something that can be very problematic. There's patients that have injured themselves because they've struck a nightstand or a wall, or actually fallen out of bed and injured themselves because of these movements while sleeping. So if you don't have Parkinson's disease, your risk of REM, sleep behavior disturbance, is very, very low. As many as 50% of patients with Parkinson's disease may have this disorder. And if you have multiple system atrophy or Lewy body dementia, your risk is actually even higher of having this condition. There are a couple of treatments that can be very, very beneficial to help decrease the dream enactment behavior. Now, you'll see that melatonin is on here as well as a medication called clonazepam. Melatonin, when we recommend this for REM, sleep behavior disturbance, I can't tell you how many patients come back and say, oh yeah, I stopped it because it didn't help me sleep at all, or I didn't feel I needed it to help me go to sleep, but I'm still acting out my dreams. It is specifically to help diminish that dream enactment behavior, and that can be very beneficial. So, sleep-related breathing disturbances. Just because you have Parkinson's disease doesn't mean you're not at risk of developing things like sleep apnea. And some people with Parkinson's disease don't just have what we call obstructive sleep apnea, they may have central sleep apnea as well. And we can evaluate that with a sleep study. So sleep apnea risk factors. So as many as 5% of people may have issues with sleep apnea. It may cause inability to stay asleep through the night. If you are heavy, you are at higher risk of developing issues with sleep apnea. If you are a man, if you are over the age of 55, you're at higher risk of developing sleep apnea. If you have big tonsils, if your tonsils were never taken out and your tonsils are a little bit larger, you're at higher risk. If you have a smaller jaw, you're at risk of developing sleep apnea. If you're somebody that smokes, if you have allergies, and who here in Michigan doesn't have allergies? If you drink alcohol, or if you take sedating medications, All of those things can increase your risk of developing sleep apnea. And this man says, oh, the doctor says I snore so loudly I have obstructive sleep apnea. And his wife says, so in English, that means your neck is fat? And he says, well, I really prefer the way the doctor said it. So if we don't treat sleep apnea, a lot of people don't want to have that diagnosis because you think about, having some space-age technology mask that you have to wear and you're hooked up to a hose and it sounds very uncomfortable and it's loud and it's going to be problematic and it's going to be hard to sleep. But what if you don't treat sleep apnea? That can lead to significant problems. It may impede your ability to breathe well through the night. If you don't breathe as well as you need to, that can decrease oxygen to your brain. If you don't have enough oxygen to your brain, the next day you can be sleepy, you can be tired, you can be depressed, you can be irritable. Your brain may not function as well as you need it to be, and you may have issues with significant memory problems. So people that have untreated sleep apnea are at higher risk of developing car accidents or just any accident in general, whether that's a fall or dropping things or injuring themselves when they're trying to prepare a meal or clean up around the house. People who have severe sleep apnea have actually much higher rates of death, higher death rates. And you can be more at risk of developing high blood pressure, congestive heart failure, having a heart attack, having a stroke, developing an irregular heart rate, gaining weight, or even developing diabetes. So sleep apnea is not just a disease du jour. It is a significant issue that we can address, and we have many, many good treatment options for it. So what are those treatment options? Sometimes it's behavioral, sometimes it's just sleeping with your head elevated, maybe it's sleeping on your side, maybe you just need a little bit of additional oxygen at night, maybe it is some sleep hygiene improvement, sometimes you do need CPAP, which is the mask that pushes air into your lungs while you're sleeping. Surgical options are available. There's a new surgery that I didn't put on here called the Inspire device, which is a little device that's implanted and you turn it on when you go to sleep at night, and that stimulates your airway so that it's less likely to close while you're sleeping. Sometimes just a little dental appliance or a mouthpiece like people that have had braces can wear, and that can often be very helpful to improve your sleep through the night. So bottom line, sleep apnea common, can be very dangerous, easily diagnosed and treated, and not only do you sleep better, but our bed partners sleep way better at all. So other things to think about which can impact sleep. So maybe we have vivid dreams or nightmares. What if patients have hallucinations or delusions? Sundowning is something that can be seen when patients with Parkinson's disease may have some early memory problems, and then in the evening hours they can become a little bit confused or even agitated, and they don't want to go to sleep at night, or they may have very other problems. Sometimes people can develop issues with seizures, and so all of these things need to be evaluated. These sleep problems, these external sleep problems, whether that's sundowning or seizures or whatever that might be, can be very disruptive. These are one of the most common causes of why somebody gets moved to an assisted living facility. Sometimes hallucinations or sundowning may be difficult to try to distinguish from REM sleep behavior disturbance or other conditions. And so if your doctor says, well, I really think we need a sleep study to try to sort this out, it's not just yet one more test that they want to order. It's because they're trying to determine what is the best way to approach this. And so there are many different ways that we can address some of those issues. So sometimes patients have frequent urination at nighttime, and So they wake up or they're trying to get that fluid in because their blood pressure is dropping down, and then they're up all night to go to the bathroom. How do we address that? Well, we want to make sure that it is, there's many different ways that we can address going to the bathroom through the night. Sometimes it's just managing to get you to sleep a little bit better through the night. Sometimes you might need a medication to try to decrease overactive bladder issues, making sure that you're not drinking caffeinated beverages too late. If you're on a water pill for heart issues, maybe you ask your doctor about taking that earlier in the day versus later in the day. Sometimes we actually need a urology evaluation to make sure that something else is not contributing to this issue with frequent urination. And that little cartoon, I don't know if you guys can read it, says, I have plenty of get up and go for someone my age. I get up and go at 1 a.m., I get up and go at 3 a.m., I get up and go at 5 a.m., and I get up and go, and I get up and go. And just a quick just a quick flow chart of how to potentially address some insomnia type things. If somebody has motor symptoms at night, extended release medications can be helpful. If they get up and go because of issues with going to the bathroom, then fluid reduction means after about 6 or 7 p.m., not all day long. There are many different medications that might be helpful. If somebody is not sleeping because of mood issues, again, there are many different things that can be helpful. Other ways to battle insomnia, sometimes listening to some soothing stories can be very helpful. Medications can be beneficial. Whoops, why did that, let's go backwards just a little bit. So there's a podcast called Bore You to Sleep, and how do we turn this up? I know the volume was an issue previously, so. Julia, do you know how to turn this up? Okay. Can you hear that? I don't know if you were able to hear that. That's actually oh, are you coming up to help us? Yep. Okay.
Hello. Welcome to the Bore You to Sleep podcast.
So we're joking about that. That's actually a video or an audio clip taken from the actual podcast. It is called Bore You to Sleep. And that gentleman, his name is Teddy, reads open source stories. And if you have ever been at a lecture and kind of dozed off, if you've ever been in a church service or a sermon and dozed off, if you were ever in a class and kind of dozed off, it's kind of that same theory that who's ever talking is not quite compelling enough to keep you awake, but your brain isn't able to shut its, not listen. And so it just kind of bores you off. It bores you to sleep. But there's many, many different ones that are available that can be very, very helpful. We've already had one lecture regarding caregivers, but I cannot ignore them. So caregivers, very, very important for all of us. And if somebody is not sleeping, that means typically their caregiver is not sleeping as well. So we want to make sure that caregivers are taken care of as well. And so we want to make sure that everybody is sleeping. So in conclusion, sleep disturbance is very, very common in patients with Parkinson's disease, We have to recognize what your sleep disturbance is so that we can best manage it. But there are many, many, many treatment options that are available, and I think this is appropriate. A good laugh and a long sleep, the two best cures for anything. So thank you so much for your attention for this long day. Great job, everybody. So, and I don't know if anybody has any questions. I'm happy to take a few, but otherwise,
Let's just wait for a microphone.
Okay.
They're coming right here. We have one up here, Angie or Kristen. Right here.
Hi,
Just get the
Dr. Taylor.
okay.
That slide you had on the REM disorders, that my mom's a poster child for those, all of those. And we asked her neurologist, could she try Sinemet, you know, the medication for Parkinson's? She had so many symptoms. And they said no because of her dementia.
Can you hold the microphone
Okay.
closer?
Okay, can you hear me?
Yeah, can you start your question again?
Yes, I'll start the question again. So, Dr. Taylor, if someone has dementia already, is that a counterindication for using Sinemet? Can you talk about the use of the medication for Parkinson's to help, you know, manage someone who has all of these disorders?
Well, if somebody has cognitive decline, but also some Parkinson's symptoms, that doesn't mean we can't use medications like Sinemet or carbidopa-levodopa. We have to be very cautious that we're not going to cause side effects in that fragile population. But the impact of medications like carbidopa-levodopa are short enough that it may be reasonable to try those. So.
Have there been any sleep studies relative to the use of cannabis?
Okay, so I could just kind of wimp out regarding my response and say, I'm employed by Trinity Health, and Trinity Health doesn't allow me to discuss cannabis. So, but while there are no studies that identify that cannabis is beneficial specifically for motor symptoms of Parkinson's disease, there are certainly several reports that identify that cannabis can be helpful for things like mood issues and anxiety and can help improve sleep for many individuals. So. Sir,
You mentioned anxiety and depression as common precursors to the diagnosis of PD, which I had, but I don't have it nearly as bad as I used to because of the medications. But what I do occasionally experience, and I'm hearing others, is this kind of feeling of apathy, if that makes sense. It's just like you're not anxious, you're not depressed, you just don't care.
well,
Do you
and,
hear
and
much?
apathy can be commonly seen in issues with Parkinson's disease. Sometimes apathy is actually untreated or undertreated depression. Sometimes apathy can be related to not sleeping well at night enough and is related to some daytime sleepiness. Sometimes apathy can be seen by a drop in blood pressure when we stand up. So there may be many factors that are contributing to that. And so you might want to explore that a little bit with your practitioner. So over here in the blue.
Is restless leg syndrome a precursor of Parkinson?
I'm sorry, I didn't quite understand your question.
Is restless leg syndrome a precursor to Parkinson?
Okay, is restless leg syndrome a precursor for Parkinson's disease? We cannot say that restless leg syndrome is predictive of Parkinson's disease. Many people with Parkinson's disease have restless leg syndrome, but we can't say that somebody that has restless leg syndrome is going to develop Parkinson's disease. We don't have that level of knowledge. So, over here in the red.
Thank you, doctor. I've been dealing with Parkinson's for about 8 years, and I've been around a lot of Parkinson's people, and the common question or the thing that comes up is when people with Parkinson's fall asleep, in this regards to REM phase after that, a lot of Parkinson's patients that I've noticed have reported that they don't have Parkinson's when they're dreaming. I mean, has there been any research as far as why there's a disconnect when we're unconscious? We don't have Parkinson's issues or the symptoms versus conscious?
You know, no, there hasn't been any research looking at why when we are dreaming, if we have Parkinson's disease, why in our dreams we're able to function or move more normally. It's you know, probably along the lines of why in our dreams sometimes we can fly. But no, we do, that research has not been done, and so no, we don't know the answer to that. It was a great observation, though.
Thanks, doctor.
Yep.
Are there any particular physicians that practice with, you know, what's like sleep apnea, but that zone in on Parkinson's to help?
So you're asking, are there specific sleep specialists that are also movement disorder specialists? Not that I am aware of. So that's.
Can you explain why in some cases I go to sleep with full-blown Parkinson's symptoms, but when I wake up the first half hour or so, I'm almost completely free of symptoms?
So that's a great observation as well, and one that many people with Parkinson's disease experience. And for those who did not hear his comment or question, it's why when he wakes up in the morning after having gone to bed feeling very Parkinsonian, he wakes up and he feels almost normal. That early morning kind of honeymoon effect or you know, almost normal effect is very commonly described by many people with Parkinson's disease. And one theory is that while we are sleeping, there is some accumulation of our brain's own dopamine, because your brain is still making some dopamine, just not quite enough of it. But while you're sleeping, there's maybe some additional accumulation, and so that when you first wake up, you're functioning somewhat more normally until that reserve that had been accumulated through the night is used up. So thank you again, everybody. Again, this is a long day, so thank you all. Did a great job.
Thank you, Dr. Taylor. Thanks, everybody. It has been a long day, but it's been a great day. I just want to thank you all for attending. It is our hope that you learned a lot today and that we have inspired you to have hope in every step. Please complete your surveys and either leave them on the table, or there is a box that you can deposit them on the table on your way out. Hope to see you at a walk or an open house or on Zoom. Thanks, everybody.